Welcome everyone to today's session of our NOW program educational webinars. Today's topic will be the central nervous system lymphoma. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the Q&A feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a question and answer. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website at www.dana-farber.org/resource center or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Dr. Gonzalez Castro to introduce our panelist.
Thank you, Sierra. Hello, everyone, and welcome to a new Neuro-Oncology Wellness educational webinar. As you know, the Neuro-Oncology Wellness, or NOW program, is an initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute with a mission to educate patients and their caregivers about brain tumors, as well as to provide resources to promote overall health and well-being. My name is Nate Gonzalez Castro, and I'm the director of the Neuro-Oncology Wellness Program and a neuro-oncologist here at Dana-Farber. Thank you for joining us. We want you to be part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We will select a number of questions for our guest to answer in the second half of the program. And today, it is my distinct pleasure to introduce Dr. Lakshmi Nayak, who is joining us for a discussion on central nervous system lymphoma. Dr. Nayak is the director of the Center for Central Nervous System Lymphoma at the Dana-Farber Cancer Institute, Center for Neuro-Oncology. She's also an associate professor of neurology at Harvard Medical School. Dr. Nayak has led and is currently leading multiple clinical trials for the treatment of CNS lymphoma and other aggressive brain tumors. She's also leading an international collaboration to validate clinical scales for the assessment of patients enrolled in clinical trials. She has authored over 80 publications covering the whole range of topics in neuro-oncology. She's a real expert, and we're very happy to have her with us today. Dr. Nayak, thank you for joining us today.
Thank you, Dr. Gonzalez Castro, for the kind invitation and the kind words, and also to the Blum Center and to the NOW program to organize this. I'm very excited to talk about CNS lymphomas.
Such a difficult disease, and one that we encounter very often among our patients here at the Center for Neuro-Oncology. I always say, and we discuss this with our trainees, that it would seem that central nervous system lymphoma is a very common tumor. But to help us put this into perspective, how common is CNS lymphoma?
So you're right. At our center, we certainly see several patients, and it might appear that it is quite a common disease. But brain tumors in general, our primary brain tumors that are tumors that arise within the nervous system, are quite rare when we compare it to other cancers. And within that, primary CNS lymphoma is further rare. So it accounts for about 1,500 new cases in the United States alone every year. So its incidence is quite low. Well, we have seen that in the 2000s onwards, the incidence of primary CNS lymphoma has been increasing in people over 65 years of age. And this trend seems to continue. Regardless, overall, the numbers are quite low when we compare it to other brain tumors, and it accounts for 6% of all of the malignant brain cancers when we think about primary CNS tumors.
I see. And you alluded there to primary CNS lymphoma. Sometimes we discuss secondary CNS lymphoma. What exactly is lymphoma? And is CNS lymphoma a tumor that starts in the brain itself, or is it a tumor that sometimes could start in the body and then go to the brain?
So, lymphoma, as the name suggests, is a cancer of the lymph cells or lymphocytes, and these occur in typically predominantly lymph nodes in the body. However, even in systemic lymphoma or in body lymphoma, there are what are called extranodal sites. That means outside of the lymph nodes where lymphoma can occur. Some of those could be breast, the testicles, bones, and other organs. And brain is one of the sites of what we call extranodal lymphomas. Lymphomas in the body are more common. Lymphomas in the nervous system are about 5% of aggressive lymphomas in the body. And the distinguishing feature between primary and secondary is this, that with primary CNS lymphoma, the lymphoma is found only isolated in the central nervous system. And here the central nervous system includes the brain, the spinal cord, the cerebrospinal fluid, and what we call the vitreoretinal space in the eye is the back of the eye that goes into the optic nerves and is considered as part of the nervous system. With regard to secondary CNS lymphoma, this is a term that we use for CNS lymphoma that occurs either in conjunction with lymphoma in the body, so you would think of it as a metastasis to the brain, not different from that. Or it could occur as a relapse from systemic lymphoma in the body, as an isolated CNS relapse, and then rarely also occurs as a relapse in the body and the brain as well.
I see. So under the microscope, we see lymphocytes when we look at lesions that have been biopsied or removed from patients. But are primary and secondary CNS lymphoma molecularly different, or essentially is the same disease that just develops at one site versus the other?
So in the past, when we used to look at these tumors from brain biopsies, they looked quite indistinguishable from systemic lymphomas. And then there were additional profiling that was done for systemic lymphoma called gene expression profiling that classified systemic lymphoma into 3 groups. Specifically what they would call a germinal center B cell type of lymphoma and an activated B cell type of lymphoma, also called non-germinal center type or non-GCB. And then there was a type 3, which is less common. And what we found was that primary CNS lymphoma fit more into this ABC or non-GCB subtype of systemic lymphomas. Then upon molecular profiling, as we started looking at the genetics of the cancers itself, we recognized that primary CNS lymphoma is a very distinct disease which has unique chromosomal abnormalities or alterations and mutations that are very specific to CNS lymphomas compared to systemic lymphoma. And so we thought of it as a very distinct disease. Now, more recently, what our colleagues in systemic lymphoma have been doing is that they're doing further analyses into the molecular profiles of systemic lymphomas. And currently, according to 2 classifications, there are now either 5 subtypes or 4 subtypes based on specific gene features unique to the cancers. And now we think that actually primary and secondary CNS lymphomas share those molecular features. However, we and others are continuing to do some more work to see if there are any additional differences, and do the ones that are present in the body differ slightly differently by the time they go to the brain, or if they're the same or not. And so more to come in the next year or 2.
Very, very interesting. It seems that as we have new tools and new ways to profile these tumors, we're learning more as we go along. But thank you for clarifying that. And we talked about risk factors at our recent webinar, and general cancer risk factors and risk factors for gliomas, which are also tumors that we see here. And we talked about radiation. Are there any risk factors for developing CNS lymphoma?
So there's one risk factor that has been associated with certain types of CNS lymphomas, and that is the risk factor of immunosuppression. What I do want to say is that we now classify separately what we call immunocompetent CNS lymphomas compared to immunocompromised CNS lymphoma because they behave slightly differently. As in very simple terms, one would think about it as when patients are on, or when people are on any immunosuppressive drugs, such as medications required for autoimmune diseases that they've been taking for years to suppress the autoimmunity or the increased expression of the immune system, that's when the body can undergo some changes. Other suggestions of when people have to undergo immunosuppressions are, for instance, in the context of those people that have received organ transplants from other folks. And so when they get organ transplants, so for example, in the setting of a kidney transplant or a liver transplant, in order to maintain these organs that have been transplanted, patients have to be on immunosuppression so that the body doesn't reject these organs. So again, this is another state of immunosuppression. And the third state of immunosuppression that we hear about is HIV, and not just HIV, but HIV leading to AIDS, which is when the immunosuppression is quite low. And so these are some of the conditions of immunosuppression that can prove as risk factors to developing CNS lymphomas that are related to immunocompromised states. With regard to immunocompetent primary CNS lymphoma, when there's no history of immunosuppression, we don't really know of risk factors. And partly this is because it's so rare that it's hard to sort of do larger population studies to know if there is a true association in that regard versus not. What does come up frequently in the last several years is, if Roundup is associated with primary CNS lymphoma. And now there are definitive clues and indications that Roundup is associated with the development of diffuse large B-cell lymphoma in the body. So there is possibility that it could be related to lymphoma in the brain too, but that has not necessarily been shown in the context of a CNS lymphomas itself.
Very interesting, very interesting. Thank you for discussing that. I wasn't aware of those data linking Roundup, which I understand is a pesticide that
Exactly, right.
had been used for a long time. Is it now banned, or is it still in use? I don't know that.
I think the jury is out on that, and I think there are still the cases that are ongoing as far as related to them.
Yeah. I was also thinking as you were discussing that there's also perhaps a fifth wave of immune suppression. As we age, our immune system becomes less competent. And I wonder, this being a disease also that affects patients of a certain age, if there's not a link there. I don't know if that's being looked at or not.
I think, that's a good point that you make because especially as I alluded to earlier, the incidence in the 2000s of the elderly has been increasing. And the question really remains, what is the true reason for that? And I think, again, the challenge really is that it's such a rare disease that making the associations can be hard because we need hundreds and thousands of patients to make association with lifestyle factors, and also with age. Age in general is a negative prognostic factor for most cancers, so I believe that in that regard, it would be the same. From an immunosuppression standpoint, just to expand more on that, those patients that are associated with immunosuppression-related CNS lymphomas have an association with a virus called Epstein-Barr virus, or EBV. And I don't believe that when we're seeing the increased incidence in the elderly, we're seeing increased incidence in EBV-related lymphoma. So it's probably some other features related to probably the microenvironment in the brain, but not necessarily immunosuppression in the body that leads to the disease in the brain.
I see. So presence of positivity for Epstein-Barr virus is a feature mainly of immunosuppressed CNS lymphoma, and those would account for less than 10% of cases?
Yes, definitely. And we see that the Epstein-Barr virus, which is quite ubiquitous in the environment, undergoes malignant transformation of the lymphocytes over a period of time that leads to the immunosuppressive CNS lymphomas.
Thank you. Thank you for that brilliant discussion. Let's meet a patient now. We always like to walk our viewers by how we encounter a diagnosis through the journey of a patient. So what are the symptoms that patients experience prior to a diagnosis of CNS lymphoma?
This is a good question. And I think, in general, as far as brain tumors are concerned, there's no, and this is not very different for CNS lymphomas too, there's no one specific symptom or sign that would make people think that or be concerned for CNS lymphomas. But what we do know is that about 60% of people do seem to have cognitive symptoms, which means they could have some behavioral changes, they could have memory problems. And, I highlight these because especially when people tend to get older and they start experiencing memory changes, or they can't remember, they're forgetting, or they're seeming to be withdrawn, people associate these with age-related changes and sometimes don't go and get medical attention. And so sometimes there can be a delay in diagnosis until people are really sick as a result of that. So I think that if there's a sudden change in, the behavior and memory, that is certainly something to think about. Other symptoms, such as trouble with walking, weakness of one side of the body, or trouble with language or visual symptoms, not being able to see, I think these are more clearer symptoms that do allow patients to go see a neurologist or at least their primary care doctor to get a head CT. But I think the difficulty with the memory is one of the things that can go unseen for some time. So what I would say, though, what is unique to brain tumors and particularly CNS lymphomas in this case is that the memory change is not going to be subtle, and it's going to progress over days to weeks. So if that is happening, it's clearly not, dementia or aging related process, and definitely would warrant a change. So if you have somebody who's been perfectly fine and then, very much on top of things, and suddenly is having difficulty with, doing, figuring out how to tip, or, forgot where they left their keys or lost their way when they were driving, that is something to take seriously and to certainly pay attention to. And then one thing that is different in CNS lymphoma compared to other brain tumors in terms of presentation is that most patients with CNS lymphomas at time of diagnosis uncommonly have seizures. where seizures are quite the hallmark of most brain tumors, particularly brain metastases and some types of gliomas. In CNS lymphomas, they're less common. It doesn't mean that it wouldn't happen, but they're less common than in the other brain tumors.
Thank you so much for discussing that. And you make such an important point that, this being a disease that affects folks on their sixth, seventh, eighth decade of life, sometimes some cognitive decline is, attributed to age related cognitive decline or perhaps a neurodegenerative process. And, we have seen this, that as you mentioned, these are patients that decline rapidly. It's in the CNS lymphoma is in the differential diagnosis of a condition that in neurology we know as rapidly progressive dementia, because it's a rapidly progressive issue that we encounter, and caregivers and patients, friends should bring this to the attention of medical providers. And obviously, brain imaging is the first step. And the best form of brain imaging that we have to characterize brain tumors is an MRI. So let's say a patient that over a period of weeks to a month perhaps becomes more confused, has an MRI, there are lesions there on MRI that are consistent perhaps with CNS lymphoma. What are the next steps for that patient? How should that patient be worked up?
So if the CT or the MRI suggests a mass, and it's concerning for CNS lymphoma based on the MRI features, we still would want to have pathology and confirm, because the treatment is quite aggressive, but it's also a very treatable disease. So the sooner we have the treatment, the better it is. And this is, before I go into how to make the diagnosis, I also want to highlight the fact that the reason to, suspect that there could be something going on, not just an age-related process or, neurodegenerative disorder or even Alzheimer's, is most people have a tendency to think, well, these will progress over time. We're not able to treat them. Whereas with lymphoma, if this is the diagnosis, these could all be reversed. And the reversal is truly dependent on how quickly we start the treatment. The longer the tumor's been there in the brain, the harder it is to reverse the symptoms and recover completely. And so rapid diagnosis and rapid institution of treatment is really key in full recovery. And we've seen this now in the context of prospective trials, even in terms of how people do over time and how long they live over time as well. So how to make the diagnosis? We now recommend, based on what are called the IPCG, or the International Primary CNS Lymphoma Collaborative Group, which is a multidisciplinary international group that came together to set guidelines for management of this disease. The IPCG recommends a brain biopsy as a first standard of care to make the diagnosis. So in the past, historically, if there was a lesion in the brain, the neurosurgical techniques weren't as good. And these lesions are sitting quite deep in the brain. So the surgeons and the doctors favor doing spinal fluid tests and other ways to be able to make this diagnosis. Now, the challenge with that is that those tests are not perfect and they can take time to make the diagnosis by the time the CSF or the spinal fluid is assessed. And so we now recommend immediately going in for a brain biopsy if there is a presence of a neurosurgeon who can safely do what we call a stereotactic brain biopsy, which is less hurtful for patients as compared to open surgeries or open biopsies. And so these can be done safely now with modern neurosurgical techniques. And within a couple of days, we can have an initial diagnosis to be able to know what is going on and institute treatment if we need to do that quickly enough. And of course, the final biopsy does take 4 to 5 days or longer to come.
Thank you for highlighting the importance of rapid diagnosis and how critical the role of neurosurgery is in biopsying our patients, a procedure that, as you mentioned, can be done rapidly and safely. So let's say that in the case of our patient, a lesion was biopsied and then under the microscope showed the presence of lymphocytes and other features that made it very consistent with CNS lymphoma. A few days later, final pathology report confirms that. Are there other tests that are required to evaluate the patient, and what is the role of these different tests?
Sure. So there are a few tests that we require. So we'll start first with, the basic evaluation. We want to see how the physical exam of the patient is. And this would also involve looking for finding any swollen lymph nodes in the cervix or axilla or inguinal lymph nodes. We also recommend doing a testicular ultrasound in testicular exam in older men to see if there are any masses palpable. And I'll come to that why in just a minute. And then we look for if the spleen is enlarged or any other physical exam findings that might suggest the presence also of systemic lymphoma. We then get basic lab tests to see how the overall functioning of the body is with regard to the bone marrow function, how the white cells, the platelets, and the hemoglobin are. And then, of course, to also look at how the liver and the kidney are functioning so that we know we're preparing for chemotherapy and that it can be tolerated. And then we're also checking for the Epstein-Barr virus, PCRs, and we also check an HIV to make sure this is not immunocompromised primary CNS lymphoma. And then there is what we call extent of disease evaluation. This truly has two aspects to it. The first aspect is determining what all parts of the nervous system are involved. So the nervous system, as I mentioned, 4 compartments specifically for this disease. And in CNS lymphoma, we think of this as a whole CNS disease. That means even though there are masses on the MRI in any one area, we actually worry that in microscopic proportions, it is present in multiple other areas. And so we're looking for these. So if there are any spinal cord symptoms, we recommend getting a spinal MRI. We like to get spinal fluid to see if there are any malignant cells in the spinal fluid floating around in addition to those lesions that we see in the brain. And then we have a specialized ophthalmologist do what is called a slit lamp exam to look at the back of the eye to see if there are any cells and masses in the back of the eye that are also there. 50% of people who have ocular lymphoma don't have any symptoms. So this is why it's very important to actually look for it, because the way people respond to treatment could be slightly different in the eye compared to on the brain MRIs as well. After we've looked at all of this, we also want to make sure that there's no lymphoma in the body. And so we like to get at least a CAT scan of the body. And if we get a CAT scan of the body, we will check an ultrasound of the testicles, because we've noted that in older men, there's a type of lymphoma called primary testicular lymphoma. And this has a high predilection for the brain. And oftentimes people will present with just a brain mass and just a testicular mass, and there are no other lymph nodes or any elsewhere disease in the body. And so we don't want to miss that. And so we would definitely want to check that. And then nowadays, instead of the CT scan, we actually prefer getting a PET scan, which is better to look at and evaluate the body disease or not. Again, in the past, we used to do a bone marrow biopsy because we couldn't really assess the status of the bone marrow by looking at a CT scan. Nowadays, with a PET scan, we don't typically recommend doing a bone marrow biopsy in addition to the PET if we have a PET. So why would we want to rule all of these things out? Because part which we'll go to in next is treatment, and treatment for the body lymphoma is quite different from the brain. And so we want to make sure this is just isolated in the brain, or do we have to deal with the body as well?
Thank you so much for that comprehensive overview of what we call the extent of disease evaluation in CNS lymphoma. Let's say that in the case of our patient, the disease was confined only to the brain parenchyma. How is then CNS lymphoma treated?
We now recognize that the treatment for primary CNS lymphoma involves two steps. The first step is what we call the induction treatment, and the second step is consolidation. Induction, the goal of induction treatment is to achieve what is called a complete response. That means, in simple words, eradicate any evidence of having the tumor. And the goal of consolidation is to prevent disease recurrence, to prevent the disease from coming back. So for induction, it is now well established that high-dose methotrexate-based chemotherapy is essential. Now, different locations in different parts of the world, and also depending on which part of the country we are in, an institutional specific, different people use different combinations of methotrexate with other agents. But for all practical purposes, high-dose methotrexate is truly the main backbone of the treatment. And then we recommend the use of rituximab, which is an antibody that targets CD20, which is found on lymphoma cells, and then some form of alkylating chemotherapy, and then consideration of the addition of a type of cytotoxic chemotherapy called cytarabine. And that forms the induction part of the treatment. Now, we know that even though majority of patients have a very good response to this initial high-dose methotrexate-based chemotherapy, about 80% will have some form of a response. And in the context of clinical trials, we've noted that complete response rates with most regimens has been between 50 to 60%, which is quite high. But even in these people where we do achieve a complete response, we've noted now over the years that the risk of recurrence remains. And these patients then are at a risk of the tumor coming back at about 50% over a course of the next 2 years or so. So what we found is that we need to give additional therapy to prevent this from coming back. Traditionally, we used to use whole brain radiation to prevent recurrence for consolidation. However, over the years, we recognized that radiation, particularly in combination with high-dose methotrexate, causes significant neurotoxicity. And this tends to get worse with age and with time. And so in this time and age, we are now shying away from using whole brain radiation, although there are certain protocols that are looking at low dose whole brain radiation, and we're still awaiting results of the neurocognitive testing at 5 years or longer on these. So then we've been investigating the role of additional heavy-duty chemotherapy, again, to prevent disease recurrence. And for all practical purposes, now based on the data, in patients younger than 70 or 72 years of age who are fit enough to tolerate high-dose chemotherapy followed by autologous stem cell rescue are recommended to undergo this aggressive chemotherapeutic regimen to prevent the risk of relapse. And this does occur to a substantial extent when such a modality is used.
Thank you for that wonderful review of the approach to treatment of CNS lymphoma highlighting the approach to induction with a methotrexate-based regimen that includes an anti-CD20 antibody and some form of alkylating chemotherapy, followed by consolidation, which we try to do now with high-dose chemotherapy, followed by an autologous stem cell transplant rescue. And for highlighting that there's a high rate of response to induction therapy, greater than 50%, but also you mentioned that the rate of recurrence within 2 years is also in the order of 50%. So important to try to offer some form of consolidation. Before we go into more detail about these treatments, let's say our patient also has systemic involvement, so he has lymphoma in the rest of the body. How is this approach varied in light of that?
So it very much depends on whether it's what we call synchronous concurrent de novo involvement, which means that the systemic lymphoma is discovered for the first time, and so is the CNS lymphoma. So if this occurs, then the recommendation is to use treatment dedicated towards the systemic lymphoma in conjunction with high-dose methotrexate. And typically, the way we do it is we alternate the systemic and the CNS treatments every other time until the course is completed. It's more challenging when patients have already been treated for systemic lymphoma and now they have a relapse in the body and the brain, because it's a second-line treatment for the systemic lymphoma, and which would have to be a different line of chemotherapy or other alternative therapies, such as the newer agents or CAR T-cell therapy, which is the second line of treatment now for systemic, for relapsed and refractory systemic lymphoma. And we would have to find a balance between that and treating the brain as well.
I see a multidisciplinary approach and taking into consideration the details of the patient and the history of the disease.
Right.
Going back to the specifics for the treatment of CNS lymphoma and methotrexate-based regimens, why does the treatment need to be given inpatient? This is something that we discuss with patients early on.
So methotrexate is given in high doses by the term high dose methotrexate. And it is a drug given over a specific time period. And the premise of it is that giving the drug in those high doses within a short period of time drives and pushes the drug into the nervous system so that it can actually have high concentrations in the brain. So you can imagine to have high concentrations in the brain for a drug that's given through the vein, it would have to have extremely high concentrations in the blood itself. This concentration in the blood can prove to be quite toxic for other organs. One of the organs is the kidney. Now, for about 24 hours, we allow the drug in the blood to remain the way it is so that it can actually penetrate to the brain and do its work by killing the tumor cells. After that, the levels in the blood go down, but they're not completely eliminated by themselves. If we allow only the liver and the kidney, which are the organs in our body that clear off all toxins from our body. So we have to aid the body in eliminating the methotrexate. And one way of doing that is by giving continuous intravenous fluids that are alkaline. The alkaline fluids allow the methotrexate to form a compound together that is then filtered out and washed out through the kidneys. If we don't do that, then there's quite a risk of the methotrexate causing damage to the kidneys by depositing within them. And so this can be quite dangerous and it can sometimes be irreversible. So in order to maintain that, we actually do have people be admitted for that. Now, if it is possible to do this outpatient, but it can be quite challenging because it would require people to have to come in the morning, receive the fluid for practically the whole day. We check the fluids, go back home, and then come back the next day again, spend all the day in the infusion center. So it becomes more feasible for actually patients to be admitted where they could be monitored continuously and the fluids can be given overnight as well. And so the clearance actually occurs faster.
Thank you. Thank you for highlighting that. How many methotrexate infusions do patients usually receive at induction?
So based on most of the studies, we've seen that at least 5 or 6 doses of methotrexate are required to achieve what is called a complete response in the brain, where we see absolutely no evidence or trace of it. And then most studies found that those that had what is called a partial response or a PR, when they got 2 more doses, they tended to have an improved response to a CR, like they changed from what it was a PR or a partial response to a complete response. So most trials now include 6 to 8 cycles of methotrexate.
Thank you. Thank you. Yeah, so that's usually a treatment with each infusion given every 2 weeks or so. That could
4 months.
spend, 4 months or so. And how do we know if the patients are responding to the disease? How often do we check the imaging? Is there a role for checking their cerebrospinal fluid?
So the best, tool that we have is an MRI right now. And so we look at MRIs every 2 months. In our center, we try to get our first MRI after the first 2 or 3 doses to make sure that we're heading in the right direction. And thereafter, we do MRIs every 2 months to confirm the response until the end of treatment, at which point, depending on whether they went for consolidation or not, the next MRIs will then be planned. Regarding the spinal fluid and the eye exam, the typical way that we monitor is that if there is any evidence of spinal fluid involvement or eye involvement, then at the end of therapy, we will repeat it to confirm that there is no evidence left. And that if there were, then we would have to give additional therapy. If there was no evidence of treatment at baseline, of disease at baseline in the spinal fluid or in the eye, then we typically don't need to follow with more tests.
Excellent. Tell us a little bit more about consolidation with the approach of high-dose chemotherapy and autologous stem cell transplant rescue. What does that entail for patients?
So this is quite an aggressive approach and something that has been investigated since the late 1990s, but mostly in the early 2000s. And over time, we have also used different chemotherapy regimens, and then finally, based on some of the more recent studies, have come up with some agents that we believe are more helpful in brain lymphomas compared to body lymphomas or treatments that have been used for body lymphomas. The premise really is that if patients seem to have tumor that responds to methotrexate, that is chemotherapy, very well, and the tumor still comes back, then it must be that there are some floating lymphoma cells there that we're not able to identify that didn't respond to the methotrexate, that live there and then form the basis for regrowing until when we can then observe the recurrence. And so the premise of doing the high dose chemotherapy is that if in a chemosensitive patient, we're giving even more aggressive high dose chemotherapy, which works in a slightly different way to then eradicate any of those floating cells that may be there or that may be resistant to methotrexate and the other chemotherapy that we're given. And then using that chemotherapy to really eradicate the disease. Now, what happens as a result of that, this heavy duty chemo not only kills the tumor cells, it can be quite toxic to the body. And so, in preparation for this, we have to actually make sure that the heart functions normally, the lungs are functioning normally, the bone marrow function is okay, and that all the organs are okay, because it will really damage, or it has the potential to damage several of these organs. And so it's, as I always say to my patients, not a walk in the park. Not that any chemotherapy is, but can be quite hard and harsh on the body. And particularly for a few weeks, patients can be quite sick and they have to be monitored very carefully in the hospital. What we're doing is before giving the chemotherapy, we are extracting or taking some of the patient's own stem cells, putting them aside in a process called apheresis, and then are doing stem cell collection. Then patients are admitted to give that high dose chemotherapy. And then the cells are given back as a rescue so that during the time when the chemotherapy affects the bone marrow function, when the white cells and the red cells and the platelets go dramatically down, the stem cells are given to help regrow back the marrow. And in about 3 to 4 weeks, people recover from this overall. But that 3 to 4 week period can be quite critical. And during this period, patients are admitted in the hospital and monitored very carefully for all possible side effects. So as you can imagine, for this process, only patients that are very healthy and can tolerate the toxicities of all of these treatments should be considered for set therapy. So it's not the majority of our patients, it's a fraction of our patients that can be eligible for such a method of consolidation.
Thank you for outlining that and explaining, what the treatment entails. I remind the viewers that you can submit questions by typing questions on the Q&A feature at the bottom of your screen. I just have a few more, Dr. Nayak. Are there other options for consolidation for patients that perhaps, have other comorbidities, are not thought to be fit enough to undergo high-dose chemotherapy with stem cell rescue?
So two options that would be considered what we call standard of care, and then of course clinical trials. So the standard of care options would be additional chemotherapy, but not the high dose requiring the stem cell rescue. And so other types of chemotherapy can be given. Namely with a drug called cytarabine, but this can also be toxic in people who are over 78 or so. So it could be an option for people who are in their 70s but not eligible for an auto transplant. And then there's the low dose radiation option, which is also considered, where half of the expected radiation dose would be given to patients. And the presumption is that by giving a lower dose of radiation, you still get added effect in terms of, recurrence risk going down, but the neurotoxicity is not as high as with the high dose or the full dose. And then finally, there are clinical trials. Clinical trials are, of course, questions that we're trying to answer to improve outcomes. And here at the Center for CNS Lymphoma at Dana-Farber, we've been involved for the last several years in not only understanding the specific genetics and the biology of CNS lymphomas, but how they progress and which patients tend to do better versus worse. And in this context, we have also been doing work on immunotherapy and cellular therapy, as well as targeted therapies. So we have several trials that we're now looking to use as options and seeing how efficacious they are in people that are not transplant candidates.
I wanted to ask you about that next, because I know you're very much involved with these studies. Can you highlight some of the studies that you're leading or participating on for CNS lymphoma?
Right. So we have two sets of trials. The first set of trials is for what is called newly diagnosed primary CNS lymphoma. That means when patients have a new diagnosis, and this could involve combining a novel agent with high-dose methotrexate and other standard of care chemotherapy. And so presently we have a study to combine an immunotherapy drug called pembrolizumab in combination with high-dose methotrexate-based chemotherapy. And then we're continuing the immunotherapy for maintenance as consolidation so that we could see if using the immunotherapy, which would trigger the body's own immune cells against the cancer, provides sort of a rescue against the lymphoma cells trying to come back again to cause recurrence. We've also had a trial of using what is called a BTK inhibitor, which targets a specific mutation and pathway that is abnormal in primary CNS lymphomas in combination with high-dose methotrexate, and then continuing this drug as well. And now we're currently also opening a study that allows a next generation CAR T-cell therapy as a consolidation for those patients that cannot go through autologous stem cell transplant. So those are for newly diagnosed. And then the majority of the trials are for what we call recurrent tumors or refractory to high-dose methotrexate, which forms about, I would say, 20% of patients, 15 to 20% of patients don't respond to the initial methotrexate. And then some others progress later on during their course. And so some of the trials include, again, what we call targeted therapy. So we target specific pathways or mutations, more commonly different types of BTK inhibitors. We have combinations of BTK inhibitors with immunotherapies. And then we also have combination of BTK inhibitors with another type of mechanism called IRAK4, which is found to be more active when patients receive BTK inhibitors. So this is for people who have previously received BTK inhibitors and now progressing as a next line to counteract the resistance mechanism so that it could then start to work again. And then we're also doing a lot of work in cellular therapies and CAR T-cell therapy. So we have trials for that as well.
Thank you so much, Dr. Nayak, for a wonderful discussion on CNS lymphoma, highlighting everything from diagnosis to treatment and new advances and new areas of research. We appreciate your time and your expertise. And thank you all for joining us today. I ask you to please complete the poll, which will come up now on the screen with a few other questions to try to make our programming better. And I invite you to join us for our next webinar, which will be in about a month on November 3rd. And we'll be joined by Dr. Patrick Wen, the director of the Center for Neuro-Oncology here at Dana-Farber, for a discussion on different brain tumor clinical trials. What are clinical trials? What are some of the trials that we're running in addition to CNS lymphoma trials for other types of brain tumors? And we'll be going into a lot of detail on that. So I hope you will join us then next month. And thank you again, Dr. Nayak, and thank you all for joining.
Thank you
Thank
both so much. Appreciate having you on today. And as I mentioned earlier, the session will be it was recorded and it will be posted on our Blum YouTube playlist. So please keep an eye out for that.
Thank you, Sierra. Thank you, Dr. Nayak.
Bye-bye. Thank you.